Test 1 2. I am going to call to order the Human Resource Committee meeting. Are there no citizens wishing to address the board? So I will now move to see if there's an approval of the minutes. And we have two today, one from the Human Resources Committee meeting on October 26th, and one from a special called meeting on November 6th. Got a motion? Second. All right. All in favor? Nay? Motion passes. Okay, thank you so much. And so we are going to move to Human Resources reports. Do we have any other? No, we didn't have any reports. There are no reports today. And now we'll move to agenda item 5. We consider of approval of proposed AIP goals. So Ashley and Jill. Jill.
I'm bringing my friends.
Yes. And all the friends.
Yeah.
We like to see a full side. Hello.
Right?
Oh, wow. Okay. So who's going to take the top of the hymn? No.
All right.
Thank you, Jill.
Thank you. So we're here today to present the FY24 AIP goals. And like I said, I brought some of my friends, my fellow executive champions of our various goals. They'll review individually for you today. So I want to give a little bit of background on annual incentive plan or AIP FY24 goals and really how we get to where we are today. How are goals developed each year? We have executive team here, other executive peers, as well as additional team members across the organization that have input into possible goals for the fiscal year. We also involve our data analytics team. They are key in determining our metrics. We also work with our external partners, so for example, Prescaney for patient experience, Gallup, employee engagement, and then as well as CMS, HHSC, Leapfrog, just to name a few of the different quality and payment levers here for healthcare. Considerations for our goals include alignment with our strategic plan. We want to ensure that. We also want to ensure our focus is always on our patients and their outcomes, our workforce and their engagement, as well as our overall financial sustainability. We also consider the network overall. Can these goals be broad enough to impact not only our patients and our employees and our finances, but also that all of our staff can work towards these goals, or as many as possible? Is it a SMART goal? So is it specific, measurable, achievable, relevant, and time-bound? And then a couple other additional considerations, again, is all staff benefit from the AIP plan, so that includes our frontline staff as well as our leaders. And then as you recall, last month I mentioned our secondary or tier 2 goals. Those
also want to thank for all costs and all payers. There are 5 reasons from our first metric also are quite severe. Both CMS and all payers look at readmissions because the payers are paying for the repeat readmission. So they want to understand how organizations can be disincentivized or incentivized to reduce this metric. Once a patient gets readmitted, it actually adversely impacts our length of stay in throughput. So essentially, it impacts the capacity of the healthcare system to provide care for others. And finally, this was a metric that we have been pursuing to excellence for the last 2 years, and we did not meet the threshold this past year. So those are in my mind, those are the reasons to consider this metric. We have done a lot of work on readmissions for the last 2 years. In FY 2022, we focused on heart failure readmissions. FY 2023 was all cause, all payer. Just today, I received information that our readmission rates for FY 2023, we finished September FY 2023 at 11.7. When we prepared these slides for you, and the slides that you might be seeing on your iPad, the numbers are a little different because the data on readmission lags anywhere between 45 to 60 days. So by the time the data gets finalized, there is a lag. And we were working with numbers from July. Our data from July, August, September has now been finalized, and I'm glad it happened today morning and not tomorrow. but the number now, we ended the year at 11.7. We have teams that are focused on all-cause readmissions and heart failure readmissions, and in the last 4 months, we have teams that have been hyper-focused on trying to improve readmission rates among patients who have gotten readmitted to the hospital. A couple of nuances, because it's very important to understand, typically talking about 0.1% reductions over time, over a year period. They don't decrease that fast. The other nuance I want you to know is I was asked to lead readmissions for PCELL for 10 hospitals starting 2018. I was part of a 5-year journey, and our 5-year target was to reduce readmissions by 0.6% over 5 years, and not a single hospital in PCELL is a safety net hospital. So those are the two things to keep in mind as we think about targets and how we get to those targets that we got to. So we had this, so when we looked, so our statistician sent us our numbers today morning. So we finished FY 2023 at 11.7% readmissions. I think holding that line and working on our patients and making sure we can stay at that target for FY 2024 itself will be a significant book of work, and I think that is the threshold we would like to propose. A 0.1% decrease to a target would be the target, and the stretch would 11.6. I do not know of any organizations that have gone and improved readmission rates within 11 months by 0.2%. I have never seen that happen. When we look at the financial implications of this, in addition to quality implications, this is another nuance to keep in mind. I'm going to take us away from all cause, all payer. I'm going to tell us about CMS readmissions alone. CMS is the only national payer that gives you national benchmarks. And we see a smaller number of patients than the other hospitals that are Medicare. We perform better than national average on CMS readmissions, which means we have a smaller group of patients that we take really, really good care of who come to, and that is very hard to do in healthcare. Actually, if you take a large group of people, you actually can perform better than a smaller group. So we result in up to $540,000 either gain in revenue or prevention of loss of revenue. So that's the impact of a really, really small percent decrease on the finance. It's about $500,000 for a 0.1%. So that's the nuance to help understand, articulate what is happening in the national environment, how well we are performing to the national environment, and the rationale for the targets that you see, the threshold to hold at 11.7, and the target at 11.6, and to hold the stretch at 11.5. I'm happy to take questions. I'm very passionate about this, as you can understand.
What was the 2022?
Right.
I do not remember that.
Okay.
I do not know that. I'll have to find out. I can follow up with you.
And how do we,
It's not apples to apples because.
well, and that's,
Colin had made those changes.
Yes.
Remember with the
Right.
ops to inpatient, so that's what threw us off mid-year with last year and why we were not able to achieve because of that change that we felt was very important to move forward with.
What was the change?
Just how we define observation versus inpatient status.
So this is readmission for patients that have been fully admitted, not in
Yes.
the...
Not
in
observation
ops.
patients.
Yeah,
Not
so
ops.
you could have played the game right and kind of put them into ops or whatever. So anyway, by changing that definition and put more of them into an inpatient status.
have any of, and I know we'll go through everybody, but for any of these metrics in comparing years 20 and 21,
Yeah.
was there a way to average out everything because
Correct.
COVID got everything so crazy?
So when we look, so I have that information. So so the last 2 years, our readmission rates were actually lower. That was because COVID just threw everything off. The readmission rates were off. So we'll have to go back to almost 2018 and 2019 to see what our rates were. I don't have that information. So to your point, last 2 years we performed better than this. This is coming back to what true pre-COVID numbers were in terms of readmission across the country, actually.
So what is this in terms of actual patient numbers?
Right.
Because it's like,
19
I mean,
yeah.
you're talking very small numbers of patients.
Yeah, so actually, so I know the number. It's we had a total of 1,099 patients who actually got readmitted to us, and they had 1,999 readmissions. So over a year, we had roughly 2,000 readmissions. Yes, it's a small number, but it's still a sizable percentage of the inpatients that we admit to.
I'm just trying to wrap my head around the percentages being that close between threshold and
Right.
stretch.
Yeah, it is a small number.
It seems like you're talking about half a person.
Yes, yes. So essentially, we'll have to reduce that 2,000 to somewhere around 1,900 and 1,900 to 1,850. I think if we do the math, that's what it'll get to. But these are patients who have significant challenges. They have a significant healthcare comorbidities. They are not healthy. They have multiple health issues. One. On top of that, some patients have a size of about 138 patients have come 600 times. They have readmissions, okay? So that patient population, not only do they have complicated medical issues, they have significant social issues and social barriers to care. So trying to get those patients and taking care of them, connecting them with resources and making sure that they succeed at home, it's not a small endeavor. That's why those numbers are so tight.
So does the readmit have to be for the same condition
No.
they came in for, or
No, any cause,
other
any
condition?
cause, yeah.
Wow.
Yeah,
I mean,
Yeah.
that is
right.
something.
Well,
So
if they go to another hospital.
if it's CMS, even if they go somewhere else.
Okay. Wow.
Yeah.
So if they got care here, they were doing great, they were on a bus to see their relatives, and they any reason they stopped somewhere else, it's a readmission we get paying for.
Are there national averages?
Yes, CMS is the only organization that has national benchmarks for this. The national average for CMS right now for that population is 14.6%.
And you say for that population, what's that population?
The population that is eligible for Medicare, so patients who are eligible for
That's
Medicare.
all of Medicare,
All of Medicare.
including Medicare Advantage,
No, it's all of Medicare.
everything.
Yeah, not Medicare. I think Medicare Advantage, depending on the plan, they might have the rate. But true Medicare, fee-for-service Medicare.
Original Medicare.
Original Medicare.
Red, white, and blue.
But how does that compare to, since a lot of your traditional Medicare have gone over to the Advantage program? So what is the Advantage program's average? I mean, I'm just trying to, I guess I'm trying to get from that 11.1 that I had to this 11.7. And what
yeah.
time frame were we looking at?
So that was about 60 days worth of data. So it was August and September. When we started to do this work, we were working of July. So we have August and September data that came back because we are November 15th now. So we've got 45 days that have gone by since September 30th. That's why as data has been updated to include those
Okay.
2 months.
All right.
But your original number, 11.1, what data did that, and what were the months?
That's what I'm saying. I think that was end of July. So the data for August and September got updated yesterday. We got that, and our statistician
You had
got,
10 months of data, it was 11.1.
correct, we had 2 months.
And, I mean, you've said moving it even a 0.1% is a huge thing, and yet it appeared to have moved 0.6% when 2 months of data came in.
Yes, getting
What
it
happened those 2 months?
So that patients readmit because of other issues that are happening in the community. So our teams are working on that. And because I've had 3 hours of work, we haven't figured out exactly the cause. One thing that we are going to be very, very hyper-focused on is to make sure that we have put a lot of effort in the last 3 months to ensure that we are discharging patients appropriately. We want to make sure we can bring length of stay to where it should be. We've done a lot of work. So we'll be making sure that that work is not in some way, shape, or form resulting in more readmissions. So we'll be having to look at every single case and understand why this readmission happened. I don't have a definite answer for you.
I have one other question on the observations. If they're admitted to observation, that's not a hospital admission, right?
No, it's not.
And so if they are dismissed and then they come back to observation,
It is not a readmission.
it's not an admission, only if they have a true admission.
Correct.
Okay.
So if they keep readmitting to the observation, so an observation patient 3
Yeah.
And then we kind of went up last 2 months. So I will be doing a deep dive along with my team on understanding what happened in those last 2 months to figure out and provide an explanation to the board as to what happened. It'll take me a couple of weeks to do that because we have to look at every single case to understand it and understand where the breakdowns were. I'll also go back to see what 2018, 2019 readmission rates are. And then compare us to what we are doing with safety net hospitals across the country to see if we can get you some benchmarks to see what's happening. I have looked at our benchmarks and compared that with Parkland, and we are better than Parkland on our readmission rates.
What is theirs?
Even for, I think they're in 12%. And even with 11.7 is actually, we are lower even with 11.7 than Parkland.
If you have a 10-month at 11.1 and then 60 days or 45 days of extra data pushes it to 11.7, that's telling me that those 2 months was like 14 or 15%, something
Yes.
like that.
Yeah, that must, that,
So I don't think we should make our stretch or our target based on our worst data for the year. That's not really a stretch.
So I think the way, my understanding is the way it does it, it's a rolling 12-month average. So we would be holding ourselves accountable to a rolling 12-month average next year to that target. So it's not just 11.7. We finished 23 with a rolling 12-month average of 11.7. So it's not 1 month that we went to 11.7. When you average the last 12 months and look at the rate, it comes to 11.7.
Right, it's a rolling 12-month average, but it took a huge spike in the last 2 months.
Right.
So the raw data for August and September, we're probably 14 to 15%.
Right.
But hopefully this is a continual downtrend year after year. We see it, inching its way down.
Yeah, that is unusual to see that much. So we'll figure out there could be another way of understanding. Did we code the data correctly? Did we actually attribute? Did we get all there are a lot of exclusion criteria. So we'll look at that work to understand why that 0.6% increase happened. But if this trend holds, then that was the logic behind saying the targets, thresholds, and stretches because of what we will think of this as a rolling 12-month at the end of FY 2024.
I just want to say it out loud.
Yes, ma'am.
That is one that continues to bother me because I looked at this all last year and for your 12 months to average out at 11.7 based on the last 2 months concerns me.
It is concerning.
That is concerning because we have not had anywhere near the 11.7 the whole time we've been monitoring this. So I'm uncomfortable with that measurement. I'll just say it out loud. So I would recommend that you bring back some more data for this one. I'm not comfortable with that 11.7 as your threshold.
Yeah.
When my whole year I've been looking at this and it has never been
Totally.
close to that.
Yeah. And one of the things that we had been talking about is making that stretch goal more of a stretch and where it comes from. I understand, I hear what you're saying on the point movement from there, but we do have to look at how are we, because I think you had said there was about 586 people that were 30% of readmission.
Yeah, those 580 encounters.
Yeah, and encounters. And what does that look like from there? So
Okay.
I think we can look at this a little bit more.
Yeah, I definitely will give you an update on the 0.6 increase that happened and the rationale for it.
Okay.
How many admissions do we have typically year-round for the whole year?
50,
Well, let
True
me give it
admissions.
to you.
40,
I mean, just a
40,000,
ballpark.
roughly 40,000.
40,000?
Yeah, roughly. I don't know,
So this would be 11, or 10% would be 4,000 readmissions.
roughly.
So every percent is 400. Or, right,
Every person
10
would be 400, yeah.
Every percent
Yeah,
is 400 admissions. And so every 10th is going to be about 40.
40. That's a lot.
That, it takes a lot of case management and a lot of resource to decrease readmission. We do see that we provide great care while they're here, we often don't have as much control on once they go home and where they go home to. Again, we have a really high-risk population. What they go home. Yeah, and what they go home to. I mean, we have a population that's experiencing homelessness. Could be our correctional health population. So understand this is not an easy group or number of patients to, even with high resource and a lot of case management around it, to bring down that number. And that's why you see such a small decrease proposed here. I would also remind the board that we've had this now for 2 years and we've not achieved it. We've not even achieved threshold with even small percentage decreases attached to it. So I hear what you're saying. I think this is still going to be a lot of work for the team.
A lot of work.
And I think
what's
too,
presented here.
we aren't mentioning too, I mean, we're talking about CMS measures, we're talking about comparisons. This is not, take into account our JPS connection members and, to Dr. Carla Pooty's point, we have a small group of people that we need to wrap our arms around that are coming back multiple times. And so the cost to the organization for not keeping them out of the hospital and keeping them well is high. That cost is high. And so I think we have 150 or so patients that come back more than 4 times in a year for an admission. That doesn't even include maybe the observation cases that we're not even talking about, because we want to prevent those as well. And so that's the hyper-focus work when you're talking about small numbers, but a large impact on 150 patients in our system that come back 4 or more times for an inpatient admission, not to even mention observation status if they come in for that as well.
I do hear you. I do know it's hard to get it down. And all I'm saying is that big jump in the numbers is what's bothering me. That out of all the stuff that you were trying to get down to, it was never at 11.7.
Which means that we're having some high readmission rates for that rolling 12. Now to throw it up to 11.7 means that we've had these months over the last, you said it's lags about 2 to
2 months, like 2 months of data, yeah.
So it means that there had to be a month in which we had high readmission that was thrown in there in order to bring that number up. So we're actually working, if we took an absolute number, we're actually working from a higher number than 11.7.
Yeah, probably 14, 15%.
Yeah, probably
Yeah,
14 to 15%, yeah.
All right.
On this same metric, last year, we used heart failure readmission.
2022.
Yeah.
Right, fiscal year 20, I'm looking at the AIP that was presented last December. And it says heart failure readmission within 30 days, just for JPS connection patients. That was a very specific
small
metric.
population, yeah.
Not a good metric,
Yeah.
very small.
And the variations between threshold, target, and stretch were about 0.3. But I wasn't here then. I don't know why they picked that
I don't know.
very narrow metric.
I was not there.
We're trying to start somewhere. We're trying to start, you segment out that whole readmission to something that we could begin to manage and then expand that work over a broader population. It was probably not, to Jill's point, the best way
Dr.
to do
Karpudi,
that.
just historically, it might be worth a comment. We have looked at what the biggest drivers were of the 30-day readmission rate, and historically it had been heart failure. Heart failure was 35% nationwide, and there's a lot of variability in the readmission rate geographically all around the country, and so if you compare yourselves, you probably, compare yourselves geographically is the best comparison. If pneumonia had a high readmission rate, MI had a high readmission rate, historically, all around the country. So we were comparing ourselves to that, and the medical staff would work together interdepartmentally to try to focus on those high yield areas that were so high. But now we're hearing that there's more socioeconomic impact that now it's not just diagnosis driven as much as it is other variables that are causing these readmissions. So again, we're going to have to look at that from the medical staff's perspective, on how we can work together interdepartmentally, not only to prevent readmissions, but to have alternatives to admissions, at each level, each department. Working on the diagnosis focused helped us because we worked on it with the cardiologist, we worked on it, inpatient, and we had outpatient solutions to that really made a big impact on decreasing that heart failure. But now it's looking at all cause, all payer, and there's multiple areas. So just historical comment on that.
Thank you.
And I will say this. I'm going to go with staff recommendations. But I just wanted you to hear me on my concerns, that if the number is higher than, like you're saying, if you come back and tell me next month and drop down to 11.1, I'm gonna really be concerned, okay?
Doesn't aftercare play a large part in that when they leave here and what they arrive back to the person who's helping with the aftercare has to be educated on how to help with aftercare to keep from getting that readmission back.
The board, and want to thank to Amanda and Ms. Dorothy and also Dr. Holland for your guidance as we were talking through things. But we are here to present depression response. Depression screening is really going to be critical to the overall wellness, spiritually, mentally, emotionally, and physically of our patient population here at JPS. It is a rising epidemic. Everybody knows that depression is skyrocketing as well as suicide. Just for your information, here in Tarrant County, our adolescent rate suicide through fiscal year 2021, they haven't released 2022 data yet, in Tarrant County was 11.2% suicide rate. The state of Texas was 7.7%. The United States was 7.2%. So Tarrant County has an extremely high child-adolescent suicide rate. And this measure is really to take a look at what we can do to address depression and suicide with an evidence-based intervention tool that will include all payers, so not just connection patients, but will also include kids age 12 and up, whereas our previous depression remission goals were adults only, and it was connection only in a much smaller population. And now I'm going to turn the rest over to my partner here, Dr. Lowy.
Thank you, Zelia. Thank you all. I have to stress how important this is. When we're thinking about depression and the impact it has, it's not only on the patient's well-being, it's on their family, and it's actually on their medical health. True. So studies have shown time and time again, when patients are taking care of their depression and their depression is treated, they're taking care of their diabetes, they're taking care of their hypertension, they're taking care of their cardiovascular disease, and we actually see improvement across the board in their mortality in this population. On top of that, going with the 12-plus community really allows us, when we go 12-plus and we go all payer, we're talking about a denominator of 56,000 patients. 56,000 patients that we're going to be trying to impact. When you look at the goal that we've put before ourselves to get a response of greater than 50% decrease in their PHQ-9, PHQ-9 is that tool that Zelia was talking about. It's a list of questions that we ask patients to measure whether or not they're depressed. A negative score or a remission score is considered 5 or below. The average number for these 56,000 patients is 16. So these patients are depressed. They are, and there are multiple factors, right? Their health, social determinants of health, their boyfriend who might have broken up with them yesterday in that adolescent population. There's so many things that we can impact and things that we can't impact, but hopefully we can try. To also add to that, When we look at our threshold, target, and stretch goals, if we're able to hit stretch at 31.65%, we will be impacting over 18,000 patients with a response. That's a huge amount of patients when you're talking about the impact that can have to this community. I do want to add in that this is a TIPS measure for our federal payment. It can be worth up to $3.4 million for our organization. So really focusing in on depression screening is so important for our patients, but also has a financial impact for us. That being said, when you think about mortality improvement and morbidity improvement, now you can also look at Medicaid and Medicare value-based care plans and their standards for A1C control and blood pressure control, medication adherence, et cetera, ED utilization, hospital readmission to the point that we were talking about previously. All of that gets factored in with these patients who aren't taking care of their mental health. And I'm open to answer any questions or concerns.
A couple questions.
Absolutely.
What do these percentages mean? Are you giving a survey, or how do you measure this improvement in the threshold, target, and stretch? And then second, explain a little more fundamentally how we could benefit financially. You mentioned some program. But
Absolutely.
So I'll answer the first part about how we operationalize this. So we have, and it's really a standard of care and above the call as far as JPS goes, but regardless of your point of entry, if it's inpatient, the emergency room, you're going to have a suicide risk assessment. In our outpatient clinics, the standard of care is a PHQ-9, and it's a series of questions that indicate your level of depression as well as potential for suicide. So this is all done electronically as well. And it's in our EMR, our Epic EMR, and when a survey is completed, depending on what the score is, et cetera, it's routed to a group of what's called transition coordinators, and these are MSW and LPC level coordinators that will reach out to these individuals and literally be with them every step of the journey until they get to a level of a response 50% or greater on their PHQ-9. It has taken the form of finding resources to pay their rent for them for 1 month, help them with prescriptions, find them food, transportation, get them into a therapist or another behavioral health provider, help them navigate the JPS system, integrate them with pain management clinic. So this is a huge partnership with community health. This is not a behavioral health only metric. This is a big relationship with community health, and it's ongoing. And we also have, just so you know, when we did depression remission, we needed to know if patients were being adherent to their medications, and so we were able to create a program within Power BI so that we could actually see the patients that were in our PHQ-9 program if they picked up their medications. And our transition coordinators would review those lists daily. And if they knew that Susie didn't pick up her medicine, they called Susie and said, "What's going on? What can we do to help you?" And also, well, there's a lot of other things we do, but those are the high-level points.
And to stress that this really is a network-wide project, that PHQ-9 is done in every single one of our outpatient clinics, specialty, med specialty, surgical specialty, musculoskeletal, behavioral health, primary care. Often in primary care, the interaction is done right there, or the intervention is done right there and then, where a medication is started, a referral to behavioral health. With our specialties, they are either referred to behavioral health or back to primary care to get the help that they need. There's actually an entire protocol in place if there's a high risk for suicide for patients across all of our frontline staff as well as our medical assistants, so that we're able to intervene with these patients as quickly as we can to help save them. To let you know a little bit more about threshold, target, and stretch, this is the improvement, right? So we're talking about a denominator of 56,000 patients. When we talk about a threshold of 26.1%, we're talking about an intervention on 26% of this population where we've seen a response of a drop of their PHQ-9 to greater than 50% of where it started within a year. 29.95% for our target and 31.65%. And like I said, if we hit stretch, we'll be impacting over 18,000 patients whose PHQ-9s will decrease greater than 50%, which when you're starting with PHQ-9s as high as 16, getting them to an 8 or a 7 or a 6 or to a 5, which is normal, is a huge impact to their lives. When you go through this PHQ-9 questionnaire, we're asking them questions not just about whether or not they're sad. Are you eating? Are you not eating? Are you sleeping? Are you not sleeping? This truly impacts every aspect of their lives and their ability to function day to day, their ability to work, their ability to do much of anything. In terms of the TIPS program, there is a federally funded program that is in place really to offset the non-Medicaid expansion states. TIPS and CHIRPS are the programs in place now. Prior to this, it was Disrupt. TIPS is more the ambulatory portion of the program, and amongst the measures in this ambulatory portion is depression response. And the entirety of TIPS is worth about $17 million. $3.4 million of that is the depression response measure. And so us achieving, I need to caveat this by the TIPS program truly is for the Medicaid below the poverty line population. A lot of our connection patients also qualify, but we're not deciding to stop with just those patients, not this time. We've done this measure before 2 years ago.
For remission.
For remission, only on connection patients. The denominator was about 2,000 patients. We did an amazing job with 2,000 patients. We've decided to go all in with every payer, every patient, age 12 up, to go to 56,000 patients in our denominator to really try to impact these patients.
Do we see a lot of patients 12 years old?
We do. So our 12 to 17 patients that are in this measure right now are 3,339. So we have over 3,000 patients that are currently with a PHQ-9 of about 16.
And then almost 9,000, 18 to 29.
Yep. We do a lot of adolescents. We have a pretty significant pediatrics program, which people don't realize, that we have pediatricians and family practice docs that take care of quite a few pediatric patients. And we have a behavioral health child and adolescent program and fellowship.
Right.
And so we are able to take care of these adolescent patients that need our help.
Does this include the school-based stuff that we're doing with?
No, the Tchd
Yep.
is separate from this.
Okay.
This is in addition to our Tchd program.
Yes.
This,
Oh, go ahead. Sorry, Barbara.
this 50,000 patient number, that's those who have been referred or those who have volunteered?
So it's individuals that have scored high on the PHQ-9. They will get an automatic referral, and then our transition coordinators will reach out to them.
It can improve our screening protocols, the more we'll be able to identify.
So the percentages, like the threshold right now, 26.1%, is that an actual look back of how JPS is done over what period of time?
Over the last year.
So the bullet point above the graph says month over month. Should it say year over year?
No, so what we're going to be looking at, and the reason we're going to look at a month over month, is because this is truly an improvement in the response. And so what we want to do is see, okay, if your response was, your PHQ-9 was 15, let's start with 30 so I could actually make it show. So let's say in October, your PHQ-9 is 30. Now in November, it's 25. We're heading in the right direction, right? And so if we do a month over month, we're looking at each patient individually month over month to see their improvement rate. And then statistically working out what that percentage is for the entire population over the year.
But what do you do with all the other months? I mean, if we're going to look at once a year, when we have 12 months of data, look back data, I have a good month, a bad month. I mean,
Yep, so we're going to see that, right? So we are going to see month over month, we are going to have good months and bad months. That's how it works. And, you know, I made the statement earlier about the adolescent whose boyfriend breaks up with her, but that can cause a patient who's doing really, really well to have a really bad month. And then life gets back on track and that number will come back down. Our ultimate goal is that by the end of the year, will have hit stretch. But we, as an organization, have to look at that month-by-month number because our team needs to know when to intervene and how to intervene on these patients.
So, and I'm just thinking from the spreadsheet, for all this. So for that, the lady that lost her boyfriend, I guess the next month she gets a better boyfriend, so her number drops. You're going to have potentially 12 measuring points for that one patient, but you probably don't measure everybody every single month. You may miss some months.
Yes.
It's only when they show up for an appointment?
Correct. So the recommendation is really that you don't check a PHQ-9 more than once a week or once every 2 weeks. And yes, we would only be checking these numbers when they show up for an appointment or when they're getting a phone call from the team to kind of check in on them and see how they're doing. Those are the two biggest touch points where they'll be getting that PHQ-9 measured. And then again, an evaluation of whether or not an intervention needs to happen because we'll have known what their previous PHQ-9 was and we'll know, are we heading in the right direction or do we need to intervene? Has something happened that might have caused them to go off track?
And if I may also say that with our depression remission that we did, the patients that we were working with the connection population during that time were so comfortable with the transition coordinators. If they weren't doing well, they would call them. I mean, so they were, it was a bi-directional engagement with our patients during this process. They would call and say, hey, I'm not feeling good. This is what's going on. And so it's a mutual interaction.
And I've got to say, as a practicing clinician, to have a patient who's severely depressed reach out for help is huge because they don't. Most of the time, they can't even get their heads out of the bed or look at their cell phones. So to have a patient actually recognize that they're not doing well because of the interactions that we've had with them and reach out for help is huge.
Okay, so for this population of 55,000 people, some you'll have one data point, some you may have 6, but you take all those data points for the whole 55,000 and then you put them in a spreadsheet. Some are going to be going up, some are going to be going down, and you're looking for in a 1 month time, an improvement of greater than 50%. So the person that was 30, they need to get to 15 or lower.
In a year.
In a year.
Yes. This won't come down in a month. I can
Okay,
promise
so
you that. The goal is that in a year, yeah, I think where you're getting caught up is the month-over-month
Right, that's
improved
where I am.
response. It's the way we're measuring it. We're measuring month-over-month instead of rolling 12 like the 30-day readmission. It's a clarification point for our statistics team more than anything else because the way they measure a rolling 12 versus a month-over-month is completely different. And for this kind of measure, a rolling 12 doesn't work because we won't be able to intervene on patients correctly in a rolling 12. We have to use a month-over-month measure.
Well, that also matches the TIPS measure.
And it also matches the TIPS
What
measure.
will you be using? I think that's the question he's
Yeah.
asking. You're looking at it month over month. So are we going to just do that month? That's going to be your answer. Or how will you calculate it for those 12 months? You're monitoring every month. I do understand that. But when you get ready to do a score for this annual plan, what will you be using? That is the question he's
exactly right.
asking.
We're going to use the total denominator of patients, the total numerator of patients that have hit a response of greater than 50% by the end of the year. So let's say that young lady who had a bad month and then had a good month, and then maybe by the end of the year she had another bad month, she's going to be a fallout. Right? And so, because by the end of that year, what we're going to be looking at is of these 56,000 patients, have we been able to improve 31.65% at greater than 50%?
If I'm not mistaken, you will be able to report out each month where we're at.
We will be able to report out each
But then you will take that
month.
full number.
Correct.
At the end of the year.
Yes,
To
Dr.
look at the
Hawkins,
total
yeah.
work that's been done over the year. But every month, they'll be able to.
Yes, there will be a
Look at
report.
who they have been able to impact.
And track.
And so they will
And this-
report that out each month where we are each month.
Correct.
This metric
And this-
also aligns with exactly how the TIPS measure is written. And so we had complete alignment with HHSC and how they wrote this particular measure as well. Yeah.
So if a patient doesn't have a data point in the final month, you go back a month or two to get their last data point?
So the way that the metric is written for TIPS is 1 year plus or minus 60 days. And so we can only go as far back as 60 days prior to September 30th of 2024, or as far forward as November 30th of 2024. It took me a second, sorry about that. And then again, that's how the TIPS measure is written. It's written as a plus or minus 60 days, 12 years plus or minus 60 days, and we've mimicked that measure, again, in hopes of being able to achieve this. But yes, if that patient did not get a measure within that time frame, they would fall out.
Drop them out of the survey.
They would drop out of accomplishing anything in the numerator.
So if you hit certain goals, the TIPS program, which is federally funded,
Yes,
they write us a check?
yes,
$3.4 million is what-
Potentially.
potentially.
Is it 0 or 3? We're going to have the JPS social app now for dating?
Or they.
I think they're trying to keep
make
us of
You know, those apps make lots of money. It might be.
The other thing I just want to mention, when we look at threshold and target and stretch, especially in this area, hitting threshold is major.
Yeah, it is.
Yeah.
It is.
So when you talk about target, you're Superman, and if you're stretch, you're Superman and Batman combined.
And honestly, whether we hit threshold, target, or stretch, we're still impacting over
Yes.
10,000 patients
Right.
at any given time. So
Right.
you are so right.
So the year that just ended, when you ran the same proposed formula that you're putting here, 26.1% of that population had a drop of at least 50%
Correct,
in their PHQ-9.
correct. And we would like to not just maintain that. Our goal really is at least target, if not stretch.
Especially in today's environment, is what they
So,
call it.
so 11.2 adolescents per 100,000 kill themselves in Tarrant County.
Yeah.
Let's not compare suicide to property taxes.
Had to go there, didn't you? Use the analogy.
But, and again, so Tarrant County's suicide rate for teens 13 to 17, which this would cover, is 11.2%.
Or 11.2
Just
per
11.2
100,000.
11.2 per 100,000, sorry, that's my bad. And state of Texas is 7.7, and the US is 7.2. So we're roughly
50%
Four.
higher.
4 plus,
33% more.
yeah.
So this isn't really part of the AIP, but what is JPS? Tarrant County, is there any kind of collaboration to lower that rate?
Oh, absolutely, there's collaborations to lower that rate, and we are certainly doing a great deal. We have expanded our child adolescent program significantly. We have added 4 child adolescent fellowships. We've increased our behavioral health residency program from 6 to 10 on top of the 4 fellows. We have expanded hours. We do.
As students are leaving home, because that is opportunity, I think, also to be able to touch the population.
Yeah.
Faith-based community is also.
Absolutely.
Any other questions for depression? All right, we're going to move on then to patient experience, overall rating bundle, and Ashley.
Afternoon, Amanda and Dorothy, for giving us feedback regarding our patient experience, also Dr. Holland. So, often we think about patient experience as a soft measure of how we're performing. And what we find upon closer introspection is really patient experience sits at the intersection of both margin and mission. And so we think about patient experience and how it really does improve quality, clinical outcomes, medical adherence to medical advice, and even beyond that, patient safety practices. But beyond that, what we know is pleasant, but one they can trust. And we also keep the lines to position threshold for the fiscal 2024 year at 75.4%. We've set a target at 70. So where we sit today, this year was at the 68th percentile. So a point percentage increase would probably have us somewhere around the 73rd or 74th percentile. Okay. Outpatient, we sit at the 23rd percentile, and I know that sounds fairly low, but the national standard is at 24, so we're just below that. That would likely get us to where we need to be for national standard. And then emergency department, we have a ways to go there. We likely be somewhere around the 21st percentile with a 0.9% increase. And so that percentile ranking, or how we rank, really is broken down by subscore. But we would see significant increases in it. Some of those areas that we're really focused on is our Tier 2 strategy. It will get us much closer to being on pace with our competitors in the safety net realm.
So that's the overall for,
That's
so
the
the
overall score.
low ones is going to pull you down, so And we have some low ones. Oh, okay.
And keeping in mind, that these are not all equal based on patient volumes.
Actually, how are we getting, I probably don't understand the scoring system, but how are you getting into the 70s when you mentioned that, was it outpatient, outpatient and ER were in the 20s?
Yes, so the way the score is calculated, it's basically you get credit for every 9 or 10 score you get. And so if you don't have a 9 or 10, it doesn't even count. And so when you look at the questions that we asked on our patient experience survey, 75.4%, that was our number, 75.4% of our respondents across all of our points of care gave us a 9 or 10 rating, so the top box score. So a 9 or 10. So we don't get credit. If someone gives us a 5 or 6, it really doesn't count in that number. So of the total number of people that we asked those questions, this is the percentage that gave us a 9 or 10 on our key questions. And so the way Prescaney calibrates this score, there are 2 questions generally for each of these different points of care that really indicate the overall quality of the experience. And you have to have earned a 9 or 10 to get credit, for lack of better words, in your top box.
So for ER, it's more like 21% are putting a 9 or a 10?
No, she was talking about percentile ranks. We're talking about kind of
Yeah,
two
two
numbers.
Okay.
One's the
Yes.
scoring number, and then where do you rank as
I
compared
see.
to other emergency departments in the country? That's really what
Okay, so 75.4% of the surveys coming back.
top box.
Have to,
And how many questions are there?
so it varies by facility. In our outpatient realm, we have 22, but that is different based on what type of facility you're at. So surgery will have a different number of questions, inpatient may have a different number of questions, emergency and behavioral.
They all have a different survey based on their
Yes.
site of care.
So when you come up with 75%, is that of the total questions or of the respondents?
Likert scale. And so you have very good, or excellent,
Zero to
great, very
10.
good, and then
Yes.
neutral, and then you have poor and very poor, right?
Of
So-
those who took the
so-
survey, what percentage of those gave you a 9 or a 10, which is considered top box?
Yes.
Top box.
And is that your overall score for that respondent, or, because they have 10 questions, some they give you a 10, some they give you a 0. I mean, how does that factor in?
Just want those, the percentage of those, if 100 people took the survey, what percentage of those gave you a 9 or a 10?
So, and to clarify, although each of these surveys are different, there are 2 or 3 questions in each survey that ring true, right? So you're thinking about kind of a subset of that score. So when you look at patient experience, the top box score, which is really what we're reporting on here, you have, let's say outpatient has 22 questions. 3 of those questions will be the same as behavioral health, as emergency department, inpatient, and surgery. And so there is a recurring thread there. So there are questions that are the same all the way across so that we can measure all the way across, but that is not the entirety of the survey.
So the 75.4, is it per question or per respondent? I mean, if I have 10 questions and I gave 9.5 and a 2 on the other 5, other 4, or other 5, how does that factor into the 74.75.4?
So your top box questions, and we're going to say for the sake of this argument is 3. I actually do believe that it's 3, but it's either 2 or 3. This score is a reflection of what the score was on those top box questions only.
I think you're asking whether it's the total number of questions or whether it's whether it's patients, percentage of patients.
Yeah, do you average that per respondent score among all the questions, or just the top box questions? Or do you take each question individually?
So it is an average of those, so the top box questions, you had to get a 9 or 10 on those top box questions. So it is an average of those same questions, is what I understand, across populations. But what I will actually do for you is I will actually get with my patient experience and come back to you and give you a full kind of rundown of how this is calculated. It's not something that is easily explained orally. I think we kind of got our hairs crossed. I was talking to Dorothy about our percentile ranking, and then we kind of.
Yeah, and I've gotten past that. I understand that now.
Do we have
Jay
the
explained that.
definition with us here?
Yes, I do.
Okay, just read the
So,
definition.
Well, it might be easier if we had a copy of the survey.
Well, there's multiple surveys.
yeah, so they're not.
Every
the
survey is
same.
different depending on where you had your
Change from year
visit.
to
But there's a
Yeah,
certain
it's-
number of questions on each
It's a
survey.
percentage of people.
They're the
because
same.
That are
Yes,
the same.
Drive overall rating.
Okay.
Yes.
Really
That's
drives
the
the says
bottom
that you're
line.
actually
All the other questions
giving
influence the overall rating, and so we look at them,
Yeah.
right, because they're drivers to the overall, but this is for overall rating, top box score.
Score is usually good and great, right?
Yes.
Yeah, that's it. Neutral doesn't count.
Usually sometimes do not count.
It's like.
Doesn't count at all. This is 90 and above.
You gotta get an A plus.
To give you,
Those are the ones I look at.
Okay.
Yeah, and we will probably get an update in the beginning year on patient experience. We typically get a pretty decent update on patient experience conversation as well. I think that usually comes in quality.
Patient experience, and so again, we didn't achieve stretch last year, and so we know we have to continue to do well and push this metric, so.
And there are not questions that we can say we want you to ask. These are.
No, these are
National
ours.
question standard.
nationally,
Okay,
All right.
all righty.
All right, employee engagement, Ashley.
all right. This measure, as you all know, is very near and dear to my heart. And from my perspective, although employee engagement has truly hard measures, and we'll talk about, how engagement affects the overall margins, for lack of better words, in healthcare, it is foundational to every goal we've discussed today. Without our employees who are engaged and focused on driving the strategic outcomes we've set before you today, it's impossible. We did really well last year on employee engagement, but what that also means is that we have an opportunity to continue to improve, and so we have set our threshold at 4.21, which is what we earned in 2023. We have set our target at 4.26 and our stretch at 4.31. Now, I'd like to give a little bit of context to those scores. If all things were equal next year and we earned a 4.26, we would be somewhere around the 92nd percentile in healthcare, which is virtually impossible to get to. If we hit 4.31, we'd likely be at the 95th percentile. And so that is a very, very, very ambitious goal that we've set for next year. But we really believe that the work we're doing is meaningful and that our employees and our patients deserve that we continue to lean into workforce in this way. And we also know that the cost of turnover continues to be a challenge that not only JPS face, but healthcare as an industry. And in fact, I just read something the other day that said for the first time in the history of healthcare, workforce and the ability to sustain workforce is the difference between profitability and not across the healthcare spectrum. So we feel confident that these targets are appropriate and that we will go after them, these very ambitious targets for 2024.
It would seem to me that if we reach target and stretch, then that's a major impact on patient experience.
It all goes hand in hand with each other, all of these measures do.
Absolutely.
Well, that would.
4.21, the number you presented to us.
That's where we finished.
That's where we finished this year.
You're looking to improve that.
Right.
Yes.
The team is looking to improve that. I think that's extremely ambitious.
Yeah.
I would, and Gallup has told us that jump that we did was really moving upstream. In fact, their question was, how did we do it? It took a lot of work, and I truly do believe that if our team stays at 4.21, even as a target, would be huge. So team, you guys are really being ambitious. I'm surprised that you're, I didn't think we were going that high. I'm just going to say, I didn't think that I had actually thought we were moving it that far up. That's extremely ambitious.
But Dr.
As
Don-
Gallup said, I mean, if we keep it even at 4.21, we are still swimming upstream.
Right.
So this is pretty much, we've swum upstream and jumped off a cliff.
But I think also that also speaks to the leadership team
I was about to
Right.
say
that you
that.
have here from you and those that sit there
Yeah.
at the table, that
I didn't have any questions. It wasn't me.
I'm not guilty. Talk about workforce being a priority for us, and we know it starts with the workforce. And so if we can get the workforce engaged, then our patients will,
Will be
benefit from
there.
that as well,
Yeah.
so.
it really shows for me the commitment to the organization.
Nursing has it down. They'll do great.
And throughout the year, I will bring into you all some of our Tier 2 goals, because what this kind of stretch really looks like is that we are honing in on our greatest opportunities and really investing there. And I'll be sharing throughout the year some of the pointed interventions we're looking to do. Okay. Yeah.
Was Dorothy's statement a biased statement, or you just thought you'd say nursing?
I was biased. Nursing.
That was clearly a lie. All right, thank you, Ashley.
Okay. All right.
We'll finish up, y'all.
Yes, we did. We're just going to go back to the lead slide here.
All right, good afternoon. Roy and I have had a chance to kind of go back to the actual slide that we prepared. One of the things that we realized is that from an adjusted standpoint, and based on the adjustment that we made from ad valorem, which you presented earlier in the financials, where we moved it down below the line, it changes the picture relative to from a trigger perspective. So, for example, last year it was based on literally a break even from an actual standpoint. At this point now, with what we had originally prepared, that was actually a trigger based on the operating budgeted operating margin for 2024. We're open to discussion to a degree and to see what your thoughts are, but we need to go back. I know Dr. Kalapudi is going to end up representing that one slide, and then we basically need to adjust our slide, if you will, and base that trigger on the actual, not the budgeted operating margin figure, because again, it really changes the picture. He had talked about it earlier when we take the actual projection, if you will, from an operating margin standpoint. But then, of course, when you net that with the ad valorem, of course, that converts to a significant negative number, if you will. So,
Yeah, and Madam Chair, may I comment on that?
Yes.
And Stan, I appreciate your saying that, because the slide, I was going to suggest we adjust it to just make no reference to ad valorem taxes. And in fact, and this is something Trent and I have discussed, even, and I'm sure DT and I will be getting into it when he gets back from Paris, even removing any money that the JPS receives that our CEO has minimal to no control over. Just money that just comes in that's not related to patient care, not related to how you perform the services in this hospital, and that could go the other way. There could be an adjustment mid-year. The Congress reduces Medicaid funding mid-year. You have no control over the Congress. So, whatever we come up with, the board would want to talk and maybe make adjustments mid-year if there's something that just changes the world mid-year that our CEO has nothing to do with. That would not be fair, whether it's a positive amount or a negative amount.
down below the line, it converts to that, but then, of course, based on methodology, we're going back, and then we're below the line adding it back. So we still come back to, from an operating standpoint, the number that you see here, but well, actually the net income changes. The actual operating margin, if you will, converts to the number that you're looking at there, that negative 514. that's
So
moving it down.
let me see if I can, try to simplify. The trigger in the past has been just break even, profit. So when you move all the ad valorem below, that becomes a huge loss. So it doesn't make sense to make your trigger a loss. So we need to rethink how that trigger is going to be established. So what's a fair proposal to do that based on the way the financials are going to be presented?
Well, what I would do is I would make the trigger a loss, and if we're going to have a trigger, and we don't even have to have one, but if we have a trigger, that loss would be no worse than either the budget or the prior year. We'd have to decide which one's more fair to use as a trigger, but there would be no worsening of the loss. Would be either at the same level or an improvement to meet that trigger. I don't have a problem with a trigger of negative 513.9 million. We come in at negative 513.8 million, then we met that trigger for the year. Now the trigger was not my only thought when we talked about meaningful financial metric. Out all year long. We've got these tranches that are verticals, and I like the tranches that the executive team's put together, and I appreciate your explanation because I know you guys have put your heart behind these, and you think there's so many things you could pick from. You had to come up with what's the most meaningful metrics we can come up with that will really move JPS forward, and you probably had 50 to choose from, so you had to come up with 4 or 5. And you can think of those as vertical tranches. So you've got 30-day readmission, depression response, patient experience, employee engagement. Those are your vertical tranches. I want to squeeze those a little bit and put in 2 more vertical tranches, and one would be an improvement in our financial performance. Now, that's not the trigger. The trigger would be just we don't get any worse, adjusting for any unforeseen changes in the world, say a change in the laws. But the trigger would be no worsening, but then there'd be an incentive for a bonus based on an improvement in our performance. That would be a 5th tranche. You've got the 4 tranches here. That'd be a 5th tranche. And then there's a 6th tranche. And I've talked to Colin about this a couple of weeks. Department of Justice Criminal Division, evaluation of corporate compliance programs. This was updated in March. What they look at if a hospital or a corporation or any entity has gotten in trouble, has not followed the law, and how hard they're going to penalize you or fine you or imprison you. And one of the things they look at closely in looking at your compliance program, and this offered opportunities for managers and employees to serve as a compliance champion or made compliance, listen to this, a significant metric for management bonuses. And so by having a tranche, and I like the 4 you've come up with, I think they're excellent, having a tranche for compliance, which I look back through several years, I don't think we've done that. Not only are we driving the culture here, and it's just already very good, it's towards a culture of compliance at JPS, but should we accidentally, or we have an employee that go rogue and something go wrong, and we've got the government looking down on us, having a piece of our AIP that is compliance driven will be seen in our favor during that situation. And they're telling you in their guidelines here, we want you to do this. So, and that would not be hard to measure. Colin and I agreed for the stretch that you could have a target of no more than $100,000 in fines in a year. And I think he said you would have met that for the year that just finished. And we would exclude any pre-existing conditions, anything we know that's out there that we're going to have to write a check for. That would not include refunds of overpayments if we found we overcharged somebody and we gave them that money back. It would only include fines and penalties under all government laws. Could be a HIPAA violation. But that would be a compliance tranche, and then you would then have 6 tranches. You'd have your threshold that you'd have to meet before any bonus is paid, and it wouldn't be, a high hurdle. It would be still a loss of $531.9 million. But then you'd have a financial hurdle that would be an improvement over that. That would be one of your tranches, and then you'd have this compliance tranche. Then you'd have these other 4. So that's sort of my proposal, Madam Chair, would be to add a compliance tranche and the financial metric. And when I've talked all year about a financial metric, I was thinking of not so much a threshold, but actually a component of the bonus.
Okay, let me let our.
Yeah, Madam Chair, I need to give the committee some legal guidance on
Correct.
that in closed. if that's
Yes,
okay.
yes. So we'll take your recommendation then to close session.
What I wanted to respond to Blake about was, I understand your tranches, but in the current format, you have a lot of hardworking leadership trying to meet these 4 or 5 goals, and let's say we hit a percentage of them, but the current structure we live under, the operating margin trigger, is $1, correct? So follow me there. And so if we missed budget by $1, we would throw it out completely. And employees would not be eligible for this percent of their compensation. So previously it was $1 above zero. Now it's going to be theoretically budget. So it's a big change. So how would you make it fair so to not have this massive shift from we've always had a fair shot at triggering and now it's a little bit different? I don't know what you were going to add.
What I was going to add, and also we talked here about budget, you were referencing actual performance. That would be my question. Would you actually, in the past it has been based on actual performance and $1 above, would you base it on actual?
I would base it on actual, and so it's fair. It would be the equivalent of 0. So it would be, you'd move, as you've done now, you'd move the ad valorem taxes.
Right.
And we may choose to move other things below the line, in which case your number's even going to get worse. But we're trying to come up with that dollar figure that our CEO controls and remove, you can't control Commissioner's Court. You don't know what they're going to do. But we come down to that number that is the number that's manageable, that management here has some control over. And that would be a negative number, but it would be the equivalent of 0. So if you had to make a penny in the past to meet the trigger, then, or 0 to meet the trigger, then based on your number here, just let's assume this is what last year's was, then it'd be negative 531.9 million. So if our operating loss, and this is in the new view of the financial statement with ad valorem at the bottom, if our operating loss is 531.9 million, not a penny worse, then you would meet that trigger. So it's not a change. We've just taken, we want ad valorem tax out of the whole picture.
And so we would stop at the operating margin because the ad valorem is going to be below it. And of course it would be, because anything below that, you have ad valorem and then you also have interest, all that we, investment income that we don't control. So we would stop at that operating margin, actual operating margin.
I think based on your feedback, we can come back with a trigger that's equivalent to 0, what you're saying.
Equivalent. So it should be essentially the same hurdle as prior years. It's just, it looks bad.
Right.
But it's not. It's just a different way of presenting your income statement.
Okay. Thank you.
Yeah.
Well, I'm not sure I want an income statement that's showing me have a loss all the time. Just hear me say that. We're sitting here saying, I know bringing the ad valorem taxes before that is an accounting process, but that doesn't mean that I have to look at it every month, because operation is going a little bit different. Yeah. Just hear me say that. I'm sitting here thinking, every month we're going to project we're going to have a loss of operation, a loss in our operations of 513 million. Is that what we're sitting there saying?
So before we go further down this road, I'd like to be able to take this and to close to talk about what that potentially could look like. And since this is something that's brand new brought up, this also will have to go through through finance as well. So, and our finance chair isn't here today. So I'd like to take that and move forward from here. to complete their presentations, and then as we move forward, we'll come through. Were y'all complete in your presentation? Did y'all have any other information?
At this time.
Did y'all have any questions on the trigger for AIP or for any of our presenters today?
It just compliments for the excellent presentation.
Yes, absolutely. Absolutely. I kind of want to take a picture of all of y'all just right there. If you see it from my perspective, it's very beautiful. And so I'm very happy with all the work and the potential work, and also it really is a dedicated point to you, Dr. Duncan, and your leadership in looking at their stretch goals, as well as looking at where they see themselves and their staff members. So thank you so much for everything that you're doing. At this point in time, I'm going to call for a closed session, and we will deliberate on the Okay, wonderful. Welcome back to our HR committee meeting. Currently, I am going to move for approval of the proposed AIP goals for 2024 as presented. Do I have a second? Reverend, second. Okay. All approve? All yea? All nay?
Nay.
Okay. Do I have, passes, right? Yeah, approval passes. Second, I'd like to propose a motion for approval of the revised AIP plan. Do I have a second? Second from Reverend Emerson. All yea? All in favor, sorry. All in favor? Any nays?
Nay.
Okay. Approval passes to board. All right. Well, thank y'all so much for discussion. Have a wonderful evening.
So your nay